I just wanted to start by introducing myself. My name is Mickey. I'm a child and adolescent psychiatrist here at UConn Health. I'm also an associate professor in the Department of Psychiatry at the School of Medicine. My specialty is in kids who are starting to develop borderline personality traits and also trauma. And I look forward to talking to you guys today about not the most cheerful of topics. We're going to talk about suicide. And I'm going to pull up my screen here. How do I do this? All right. Sorry, the Zoom thing is kind of covering up the menu for the slideshow here. There we go. All right. So um our topic today is suicide in adolescence. I'm also going to spend some time talking about non-suicidal self-injury, mostly in the context of it being a risk factor for suicide, but it's also just an interesting subject too. So we'll give a little bit of time to both things. And my hope is to spend some time not just talking about the larger public health issue of suicide and self-injury, which I'm hoping to convince you is a major public health concern, but also how to assess kind of what are the risks, what are some of the most recent research on the individuals who are making attempts and completing attempts, followed by some insights and ways of formulating non-suicidal self-injury. And lastly, just we're going to discuss a case just to kind of round it all out. Now, I've never done this virtually before. It's always been done kind of in a group format. So we'll figure out how to do that. Maybe we'll employ the use of the chat function on Zoom, or if you guys feel comfortable, please jump in. And then lastly, we'll talk a little bit about what to do about young people who are suicidal. All right. We got a lot of time. I do have a bunch of things to cover, but I think we have plenty of time to jump in if you guys have questions or if there's things that you want to discuss. All right. So without further ado, let's talk about the public health issues. So suicide in adolescence is a big deal, and it's actually the second leading cause of death in young individuals from 10 to 19. The first leading cause being injury or by accident. And for boys, it's about 18 out of 100,000, and with girls, it's about a third of that. And we'll go into some detail about how it looks different in boys and girls. Now, sounds like someone may have a microphone on. So, anyways, even it's one of a leading cause of death, but it's also rising now in 14 to 19-year-olds. It's rising precipitously. Sorry, 15 to 19-year-olds, and even more so since COVID. But the even younger kids, 10 to 14, should not be ignored, and the most current recommendations are saying that we should screen in these age groups too, because it is also rising in that group. Between 2000 and 2016, there was a 30% increase. Now, the estimates since 2000 or 2020 have are larger than that, but there's some disagreement about how much larger. There's been some estimates that say that's close to 80% increase since COVID. Probably more conservative estimates are about a 50% increase since prior to COVID. Now, if you look at what's happening in emergency rooms, there's a huge increase, and this is just in terms from a medical services perspective. It's a crisis because our ERs are being overloaded by kids presenting with suicidal behavior or suicidal thoughts. The rates doubled from 2008 to 2015. And if you look at all comers, all pediatric comers to an emergency room, regardless if they're coming for an injury, a cough, or for a psychiatric issue, 30% of them screen positive for having significant risk for suicide. And that's, concerning behavior, suicidal thoughts, um, history of self-injury. And in that same population, I think it was about 15,000 admissions to the emergency room, almost 20% of them had actual frank suicidal behavior. And if you look at that ER data, that's the most problematic in fall and spring, which we kind of think correlates with the more stressful times around school. Winter's about in the middle, and summer is a pretty quiet time in terms of emergency room visits. There was an interesting anecdote in that study, though, that there was some increase in individuals with autism coming in more during the summer, maybe because of the transition and the lack of structure. And the sobering thing to take note of here is that for the vast majority of these young people who complete suicides, most of them saw a healthcare provider within 2 months prior to that. So we're seeing people that are at significant risk. And in terms of just kind of suicidal behavior and thoughts, it's exceptionally common. If you just screen high school students, and this is back in 2003, and we know that the numbers have increased since then, but just to sort of illustrate the point, close to 20% of kids are thinking about suicide, even to the point of having plans at some point in the past year, okay? Now, in terms of actual attempts, in 2003, for girls, it was a little over 10%. Boys, there was a lot less of attempts, but we'll talk, like I said before, some more interesting information about the gender factors. Males were under 6%, so about 30% less in terms of attempts compared to girls, but actually requiring treatment was around 2%. Now, where we come into this is the risk that mental illness poses on suicide. It seems intuitive, right? Depression is the major risk factor for suicide amongst youth, but it's not the only risk factor, okay? If you look at all completed suicides, 90% of them could have some or have a diagnosable psychiatric disorder, either one that's been diagnosed and treated or through chart dissection, revealing symptoms that would meet criteria for a psychiatric condition. That's usually depression, but there's a lot of other ones we need to think about. And, if you look at our ability to treat individuals for depression, there's a lot of correlation between risk and completions. And just one example in terms of medications, which, definitely isn't our only intervention at all, but just using that as an example, there was a temporal association that was described in 2004, looking at 15 countries, about a dramatic drop in suicides along with the increasing rates of SSRI prescription. And then in 2004, this dropped, and then we saw a significant increase of suicides thereafter. So the general thought about the real risk of increased suicidality with SSRIs is that it's probably less risk than that posed by depression. So just to say that again, depression and antidepressants both have some risk for suicide and suicidal thoughts and behavior, but depression is a far greater risk. Now, even though depression is the one that we think about the most, anxiety, personality disorders, bipolar, PTSD, eating disorders, disruptive behavior, substance use are all major risk factors. And I'll get into sort of the relative risk with each of those. But before I do that, just to kind of nail down this depression risk, if you look at ideation and attempts compared to non-depressed controls in adolescents, it's there's a 3 times increase in risk for both of those things. So 18 versus 60% with suicidal ideation, and 8% versus 30% in terms of the actual attempts. All right, so this is what I was talking about before on this slide here with different diagnoses and the actual odds ratio of risk with different diagnoses. Now, depression, you can see, is 12 times the odds, but also, interestingly, oppositional defiant disorder is a major risk with 7 times the odds. And similarly, eating disorders also about 7, and bipolar just under 9 times the risk. So to me, I think the of these different disorders, the one that seems the most under-recognized are disruptive kids. Okay, the naughty kids who are angry and resentful can be very, very risky in terms of suicide because their attempts tend to be more violent in nature. Okay, so gender. So there's definitely truth to the fact that males are completing suicide a lot more often than girls, and this is something that is widely publicized and known. But what's underneath that is a little bit more interesting, and I think there's a little bit of complicating information to that. So yes, there are more completed suicides for boys, but ideation, thinking about suicide and actually making attempts, is much higher in girls, at least here in the United States. The greater increase in completions for girls, though, over the past 40 years is increasing. So even though boys eclipse girls in the rate of completing suicide, girls are very gradually catching up. And in some areas of the world, they actually complete more than boys do. So if we look at Bangladesh, China, Myanmar, India, the Maldives, Fiji, the suicide rates aren't even just a little bit higher in girls, they're significantly higher in girls compared to boys. So there's some interesting, probably cultural differences in terms of the ways in which people are attempting, and also the natures of the risk factors. Okay, and I think that would be a very interesting lecture in and of itself, but I'll leave that to somebody else who's more knowledgeable about it to discuss. Speaking of different groups that have significantly different risks. LGBTQ, especially transgender, also has a much greater risk of not just suicide attempts, ideation, but also completions. Interestingly, the assigned gender at birth also poses some risk. And what I mean by that is that, so all of our transgender population has a greater risk for suicide, but if you look at male to female or male to non-binary, that's the larger group. So it's sort of that maleness at birth is sort of equivalent to the increased male risk also in sort of the general male-female differences in risk. Now, so another interesting thing about gender here is that, depression is the major risk for both boys and girls. But if you kind of look at sort of what's next on the list for the different genders, after depression for males, antisocial personality traits, as well as disruptive behavior is sort of next. Now, if you look at girls, after depression, bipolar, trauma, and what I mean by adjustment there is suicide in direct reaction to major life events like a breakup, parental divorce, this kind of thing, and then eating disorder. There's also significant differences in how they're making attempts. Okay. Um, Boys just tend to do more lethal things. So you'll see a lot more of the green for boys, and particularly as boys get older, and that's guns. Okay. Whereas girls, you see a lot more of the purple and to some degree yellow, particularly in the older or in the younger groups. And that's hanging and poison, which tend to be less, I hate using the word, but less successful. Uh, can't find a better word, but I don't like that I use that word. But so boys are using more violent means. And then lastly, in terms of demographics, ethnicity, our white patients and our native patients are at the greater risk, and more than 2 times the risk in those two populations compared to other ethnicity groups. All right, so what it is, let's go into a little bit more into the clinical phenomenon of suicide and what are the risks that lead to it and what are kind of the motivations. All right, so causes of the suicide death. So, as we were talking a little bit about the gender differences, different methods lead to different rates of completions. So if you look at those who completed suicide, it's most often firearms, then hanging, and then, as I was saying before, overdosing is very rarely successful in completing suicide. Okay, so if you have an individual who's presenting with suicidal thoughts, some of the things to think about in terms of their individual risk. After psychiatric diagnoses, as we've talked about before, the next biggest thing is their history of previous attempts. So if there is a completed suicide, almost a third of them have tried before. And if you have someone who is telling you that they've attempted suicide in the past, or they engage in non-suicidal self-injurious behavior, they have a 12% risk of completing suicide. And then if they do both of those things, which will often be the case, that's about a 20% risk. However, even though those numbers are big, guys, it is important to keep in mind, and another thing that kind of gives us sort of humility in all this, most people who do complete suicide, it is their first attempt. And we just had someone in our clinic recently who never had any suicidal behavior or suicidal ideations, and had no risk factors, but had a bad breakup and a lot of alcohol and some of the other factors I'll talk about later, some of the more psychological factors. So depression, past behaviors, and then their emotional state. So not just depression, but also anger. And there's some very interesting research recently about sleep problems and suicidality. So individuals with sleep apnea, sleep behavior, or chronic insomnia are at tremendous risk for not just self-injury, but also suicide. And as I mentioned before about our disruptive patients, impulsive aggression is also associated with suicide risk. Not so much kind of planned out, calculated aggression. And then as you all know, substance use is not just acute intoxication, but also patterns of chronic substance use are major risk factors. And then to talk a little bit about the psychological factors, hopelessness and problem solving are the things to be looking at. So in terms of hopelessness, if someone had a recent life event where they feel that they have less expectations for their future, think about a kid who just had an injury from a sports injury and is no longer able to play sports, or a kid who just found out that they got turned down at all the colleges they applied to, or their family is newly homeless. Whenever a kid sees very little on the horizon, that's a significant risk, particularly if you notice in the way they're describing it, sort of feelings of futility, low motivation. And then these factors, not only are they correlated with suicide risk, they're also very much correlated with depression, as you can imagine. And then also those kids who have difficulty with problem solving, who, if they say, well, I've tried this one thing, it didn't work, and they're giving up. If that's kind of the pattern that child has when it comes to navigating life issues and existential issues, they may be more prone to giving up also in terms of life. And what are the different motivations that you'll hear? Now, some of this information comes from reports and interviews from parents about things that kids had said and done prior to their completed suicide. So one of the biggest things with suicide completers, not necessarily suicide attempters, was this kind of anger, retaliation, revenge kind of suicide. Like, you'll be sorry when I'm gone, that kind of thing. Like, mom wouldn't let me go to the prom, so she'll be sorry when I've killed myself, or my girlfriend broke up with me. She's really gonna regret doing that when she knows I'm dead. Those kinds of thoughts, particularly in an individual with poor problem solving and who's impulsive, is a recipe for significant suicide risk. Those who are looking to escape overwhelming pain, if you've got a kid with a chronic pain disorder, medical illness, or overwhelming emotional pain, like there's a lot of domestic violence in the households that's unrelenting. So they just want to escape. One that I've never seen personally, but that did come up in this study that I'm quoting here, is to join a deceased loved one. And then lastly, very notable, but very, very rare, is when there's a psychotic motivation. Like, I'm killing myself because Jennifer Lopez is telling me in my head that I have to kill myself. But this age, adolescence, is when kids will have potentially their first psychotic breaks. And then family factors. We know that suicide risk does run in families. That's why, when we first evaluate a kid, asking about family history of suicides is important, because there's some genetic things as well as behavioral things. So if you have a family where there's very little cohesion, where there's a lot of kind of isolation within the family, or if it's high conflict, certainly if there's abuse, that's a huge risk, as well as impulsive aggression, not just with the kid, but if that's being modeled by parents or siblings, that kid's going to learn that impulsive, violent acts is how to manage problems. And because suicide in a lot of ways is an impulsive, aggressive act. But besides these more kind of behavior and psychological reasons for suicide risk to be transmitted in families, there's also genetic and physiologic things. So we estimate that the heritable risk through twin studies is probably as high as 50%. And we think that it's not even just due to certain psychiatric disorders being familial. There may be something related to how serotonin, 5-HT, is metabolized or transmitted or received. And I'll get into some specific markers later about that. And then environmental risks. So, I have no intention to get political about this. And in different places where I've practiced, this is kind of, I used to practice in Washington, and I saw a lot of people in rural Washington and up in New Hampshire, and where I was seeing patients from kind of more rural areas of Vermont and New Hampshire, so where guns was just a major part of life. But the truth of the matter is, no matter how you feel about guns, as soon as you have a gun in the house, the risk of a suicide occurring in the house goes up dramatically. And so, at the very least, educating families on that. And, even in the most gun-friendly families I've worked with, I think that the love for the kid usually eclipses this, and I've never had an issue bringing this up. That, like, while Johnny's suicidal, let's have the guns moved to your brother's house, or be temporarily locked in the storage somewhere. That's a huge risk, because a lot of times suicide is just an impulsive thing. And if you have a very definitive way to kill yourself on hand, it sort of feeds into that impulsivity. Contagion effect is also a very real risk. It used to be that, and this probably still exist to some degree, used to be that whenever there was a suicide, at a school, that it was not reported on, and it was purposely kept out of the news because of this very real risk. But now with social media, these aren't kept quiet at all. It's sort of everybody kind of knows about suicides when they happen. And it just, similar to what I was saying about guns, is that, so if you're feeling this sort of impulsive idea of, I want to end my life, and then you have this knowledge of, well, okay, somebody else in my school did this, it becomes more of a real possibility. There's also a risk too, of not just within a community, but also if a famous person has committed suicide, that also can lead to some contagion. There is an increase in suicides in Korea. I think I remember reading about this about 5 years ago. There were several K-pop stars who had, I think like 3, within a span of a couple of years, had committed suicide, and they noticed a correlation of increased suicides in young people in Korea. Stressful life events are also major environmental factors. The biggest ones are, death of a parent, particularly for a very young person, but also romantic conflict. Like the case I brought up earlier, bullying. In the month following a event of bullying, there's 3 times the risk of a suicide completion. Divorce can be a very difficult time. And absolutely, and this is something I see a lot of just because I specialize in trauma, but after sexual assaults, there is a very dramatic increase in suicide. And that should, when you're working with individuals after sexual assault, there should always be very frank discussion about safety, even if they're not presenting for suicidal ideation. All right, so high-risk groups. So in our LGBT patients, up to 6 times higher than cisgender and heterosexual groups. Homeless. I don't know if this group, it works much with homeless, but this is a population I've worked with a lot, and it's a very, very big risk factor. And they say that I'm quoting a quarter here, but I've read up as high as 1 out of 3 homeless youth will attempt suicide. Similar with incarcerated adolescents, I think these are just two very disenfranchised groups, and it kind of fits with kind of the hopelessness that we talked about earlier. That that there is in our juvenile justice settings, there is a lot of attention put to safety because this risk is very well recognized. Okay, and neurobiology. I had mentioned that the familial risk earlier, and we do think that probably this specific risk towards suicide comes down to serotonin metabolism. So the end result being, when we've looked at these people who are attempting, most of this research is done in suicide attempters. We found markers for very reduced levels of serotonin transmission. And the way that we detect that is through metabolites in the CSF, as well as aberrant genes that translate to proteins that are involved in serotonin metabolism, synthesis, or transmission. So if these genes are disturbed, as they are in many of these individuals, serotonin transmission is impaired. All right, so earlier in our conversation today, we talked about non-suicidal self-injury posing a risk for suicide. So it's kind of interesting. In some ways, if we have a young person who comes and tells us, okay, I'm cutting myself because it relieves stress and it manages my feelings of frustration in a way that makes us kind of sit back and relax a little bit, because that tends to not be related to imminent risk of suicide. But if you look at this group as a whole, there is an increased risk. So about 12% of our self-injurious kids will make an attempt. Actually, no, will have a completion. I think the attempts is even significantly higher than that, but I forget the number for that. So if you pull, I know us as a group, we see it a lot. We understand how common it is because we see it in our work every day. But just to put some numbers to it, that I think would be surprising to people not in the business like us. Up to a third of kids are hurting themselves, and it's increasing. So this study was in 2008, and I haven't found anything more recent that was done with the quality of this study. But if you look at late 90s, it was more like a tenth of kids were engaging in self-injury. So it's definitely increasing. And another interesting sub-conversation could be sort of why, because that's something I like to ponder, but that'd be too time involved of a tangent. So I'll avoid postulating on that. But self-injury usually starts in mid-adolescence, and it's usually self-limited. 4 out of 5 times, it's only done once or twice, and they never do it again. It's more often girls, but boys, you'll definitely see it, and it's not suicidal by definition. But 70% of kids with here's the number I was looking for before, of non-suicidal self-injury will have at least one occasion of ideation or an attempt. And as I mentioned before, 12% of them will complete suicide. So who's cutting? Well, there's a lot of roads that lead to cutting and burning and self-injury. And to me, it sort of seems like there's sort of subgroups. There's the really impulsive kids, and then there's the ones who are really emotionally reactive. They just have a lot of feeling. And then there's another group that are just very avoidant kids. So those are sort of 3 sort of kind of like subgroups of self-injurious kids. not even to mention the developmentally delayed, and to add further complication. But also, we do know that if there's low emotional expression or speech pathology, that's a greater risk for things like cutting. The thought being, I can't get my emotions out, so I need to act my emotions out. Those who are bullied are at greater risk. Those who know others who do it, that's a risk because it kind of introduces the idea. And then also our gender diverse patients are also at greater risk for non-suicidal self-injury. Historically, I know when I first trained, it was thought that kind of, well, self-injury is more related to borderline personality, it's more related to eating disorders and developmental delay. But I think there's been movement more to think of it as a non-specific symptom that can be found virtually in any diagnosis. Okay, it's just as a medical metaphor, cough is sort of a symptom for many infections. So it's a sign of suffering and disturbance in behavior and expression, but it's not specific to diagnosis. And in terms of developmental delay, only about a very small percentage of individuals with developmental delay are actually cutting or engaging in self-injury. And it's usually those who are nonverbal. Okay, and that can look like a lot of different things. It could be head banging, it could be biting. The rates in eating disorder is, more than a third of our eating disorder patients are engaging in self-injury. And there's also a very strong link to abuse. Okay, so if you have someone who's cutting or burning themselves, definitely be thorough in thinking about screening for abuse, particularly sexual abuse. There was this meta-analysis that came out in 2019 that did kind of question the link between abuse and self-injury, mostly because it couldn't separate the risk of mental illness and abuse. So, because we know that both self-injury and mental illness are just increased in those who've experienced abuse. So we couldn't separate them as separate risks. So as I was mentioning, thinking of self-injury as sort of a non-specific symptom of suffering, maybe one good way of looking at it clinically is just looking not so much about the diagnosis, but the function of that behavior. Okay, so the function can be a lot of things. Real common one is affect regulation. A kid will tell you, I just need to get my mind off things, so I'm going to cut, or we need to release tension. So more than about half of kids will say that kind of thing. But there's also some truth to some kids just having a lot more feeling. So if we look at non-human models of self-injury, if you look at monkeys who have self-injurious behavior, they notice that their response to stress is different than other monkeys who aren't engaging in self-injury. So there's like a blunted cortisol response, and even while hurting themselves, banging their heads, there will be, or biting themselves, there'll be a decrease in their heart rates. So there is something different in the way some people feel feelings, particularly as suggested here in the people who engage in self-injury. So there's this one function. Okay, I want to stop feeling the way I'm feeling, so I'm going to cut myself. There's the opposite. They're seemingly opposite. I feel numb and I don't feel anything, and I'm going to do this because I want to feel something, or I'm dissociating and I want to sort of be back in reality. So those are two big things. And a third big one is it's used to manage interpersonal dynamics. I'm sure you guys have seen this, where mom's, I'm going to use a very manipulative, obvious example. But mom didn't let me go out with, everybody to the park, so I'm going to cut myself. Okay. So before I get to this case, I've presented a lot of material, and being that I'm probably a little over caffeinated, I presented it very quick. So before I get to May, my 17-year-old girl here, what kind of questions do you guys have or thoughts? Okay. Well, then I maybe will jump into discussing this case. So this is a kid I saw in primary care. So I do some work where I'm embedded in the UCONN's family medicine offices, and where they consult with us when certain mental health issues come up, and which frequently happens with in family practice offices. So, anyways, May came in. She was a 17-year-old girl, uh, previously very, very high functioning. She had a recent breakup with a girlfriend, and but had no psychiatric history. When you looked in her chart, it was just sort of yearly checkups, like pre-sports, physical exams, maybe a cold or flu here and there. I don't even think really that. I think there was a concussion too in her past history. So she had a breakup with her girlfriend. They'd been together for 3 months. Um, Parents are divorced, ostensibly an amicable divorce, but I'll tell you, when you're sitting in the room with May and her parents, didn't feel the most most comfortable. It felt pretty tense to me, but ostensibly amicable. But they divorced maybe 2 years prior to this visit. She's the captain of the field hockey team, and the season's coming to the close in 3 weeks. Okay, now because this is a large group, I know it's kind of clumsy chiming in on Zoom. So maybe um, on the chat, I don't know if this is corny for you guys to do, but maybe this could be interesting. In the chat, maybe pick out some risk factors, but also some protective factors that maybe you're thinking about, May, or other questions you might have. Yeah. So the seasoning, that's a very good point, because we talked sort of about kind of future orientation being something to assess. And, you know, this field hockey was a big source of self-esteem for May, and things seemed a bit bleak thereafter. I will add, though, she was a top student too. So she kind of, there was a lot of things that were affirming her self-esteem. But yes, she there's she received a lot of recognition in a lot of different ways. So a protective factor absolutely is the hockey team. Um, any more risk factors? Yeah. So divorce is a huge risk. Um, and the recent breakup, absolutely. I sometimes you'll have a kid who is so high functioning, and the one thing that comes along that sort of threatens the high functioning. I actually a child I saw this morning who very accomplished singer, very accomplished student, actor, and first time had a didn't get the lead part in the school play, and everything came crashing down, and had a lot of cognitive distortions about the future. Yes, her sexual orientation, absolutely. And I'll add that her mother, who she lives with, is very supportive of her sexual orientation. Dad is not at all. And it's been a huge point of contention. So yes, that is a big risk. Any other questions you'd like to know? All right, well, I'll move on, but I'll keep the chat open if you guys think of more. Um, um, all right, so risk signs. And now we're going to get into sort of how the patient is presenting, sort of how they're talking about suicide, how they're looking in the moment. So the more sort of kind of microscopic on the ground type of risks. So when you assess the types of suicidal thoughts, you think about the frequency that they're thinking about it, the duration, and level of preoccupation with death. Like, so, you know, are you thinking about this all day? Have you thought about this in the past? Is this every day? And when you do think about it, is it sort of like a single-minded determination of, I need to be dead? Okay. Uh, and the intent. So, why do you want to commit suicide? If the focus is a lot on sort of kind of, well, I want people to know this, I want people to know that, or it's, I want to be, so actually looking at sort of what their plan is and what they think is going to be the outcome of it. Were there past attempts? What means did they have in mind? So if they said, well, I'm going to use a gun to shoot myself, but the parents are saying there's absolutely no gun that's accessible to them, then that's different than, yeah, dad's got, three guns in the closet. Or if you have a young individual who, a 10-year-old who's saying they want to commit suicide and they plan on walking into the ocean. I used to live in Los Angeles, and that was a big one that kids would say, and that's probably not going to be lethal. Or I'm gonna take 5 of my Zoloft pills. That's probably not going to be too lethal either. So sort of assessing the availability and lethality. Other concerning things are if they're concealing what their plan is. Like if their plan was to do something, when no one's at home, or they were going to go elsewhere to do it. Or if they start gathering the instrument that they're going to be, like, say they're gathering pills over time and they're hiding them. And then also if there's active mania, active psychosis, they're in a depressive episode, as they're presenting for suicide, those are concerning things. And then also alterations in their judgment, if they're just, in terms of their overall temperament, they're impulsive or hopeless, or if they're acutely intoxicated. So going back to May, she never had suicidal thoughts before. She did say that her wish was to die, but she also said that she just wants to stop feeling the pain. She never made past attempts. The means that she was planning on using was overdosing, but she didn't even know what med she would use or what pills were available in the house. There was no preparations at all. When I screened her for psychiatric disorders, it seemed like she was acutely upset, but there were no symptoms of neurovegetative disturbance. There was no past history of depression. There was certainly no thought disorder or mania. And even though she was quite demoralized about this breakup, she did, when I sat and talked with her, she did have hopes about, playing field hockey for college. She had just gotten college applications out. She was very hopeful to be able to move to Boston. And she's never been an impulsive kid. So there's adding things up for May. We were doing pretty well, but she was still kid suffering, so we still needed to help her. So the safety signs, ambivalence. Well, sometimes if you ask a kid about suicidal thoughts, they may kind of hem and haw and say, well, sometimes I think about it, but I don't really want to do it. So, ambivalence, that's a positive sign. When the motives are mixed, when it's partially to end their life, partially to end suffering, but it's also partially an expression of distress, that's a positive sign. if they have lots of supports. Now, May had a very well-developed support system. Yes, she had the divorced parents, but she also, had the team, she had friends, she had some other extracurricular activity. I can't remember what that is now. And her parents, although they were divorced, were very present in her life. There was good monitoring. Mom was very involved and knew kind of where she was. Religion, we kind of always ask about this in sort of the suicide risk assessments. But there's been some contradicting evidence in this. They'll sort of in this one instrument we use here at UCONN, it asks if there's religious beliefs that would sort of shun suicidal behavior, and and that being a protective factor. There's been some research that actually religion and its impact on suicide risk is more about hope and community, and this idea that people won't commit suicide because it's a sin may not be as protective as we previously thought. It's more that religion can be protective because of the community and hopefulness in terms of faith. If the kids be able to communicate. So this kid was very communicative, came into a doctor's appointment saying, I'm suffering, I'm struggling, and was motivated to ask for help, which is another safety sign. And she also said very clearly what led to this symptom and these thoughts, and that ability to accurately describe emotions is a very positive safety sign. So what do we do with all this? Like, as clinicians, how do we think about the public health issue? And American Academy of Pediatrics, American Association of Child and Adolescent Psychiatry put together some kind of recommendations. And this is sort of a synthesis of all those recommendations. So said that a yearly screen for those over 12, and whenever the chief complaint that they're presenting to you is suggested. And this was kind of more of a primary care type of recommendation. But it does translate to our work in mental health that, my focus is more clinical today, but just thinking kind of in terms of litigation, if there is a chief complaint that is an increased risk of suicide that you're seeing a patient for, and by definition, all of us are seeing patients for things that increase the risk of suicide, there should always be some kind of screening and documentation that you had thought about suicide and safety. And then further, to consider screening for those over 10, ages 10 to 12, not necessarily if they're presenting for, definitely if they're presenting for depression and things like that, but also for non-specific complaints. Because younger people, if they come in for ill-defined stomach aches, headaches, physical weakness, missing school, these sort of non-specific things should also trigger screening. And the two, besides just asking about suicide, the primary care instruments that are used to screen are the PHQ-9 and the ASQ. That's it for us in kind of the mental health world. We don't use those as much for screening, maybe the PHQ-9 to track progress in treatment. But I feel like in the mental health world, we're using the CSSRS, the Columbia scale, more so. I'm curious what you guys do, or what if you have a procedure or protocol. When you are screening, I'm not going to spend too much time talking about this because you guys know this because this is your profession, but talking about the limitations of confidentiality. Some interesting thing though about working with parents and suicide. More than half the times, most of the time, parents are not aware of their kid being suicidal. Okay. And interestingly, when the parents think that their kid is suicidal, most of the time they're wrong. So parents, are an essential part of our assessment, but they're often wrong. And in terms of where I got these numbers, there was one demographic group that thwarted these numbers. They didn't go into explain this or theorize about this, but Hispanic parents actually were aware of parents being suicidal or the kids being suicidal and were often not wrong. So it's sort of that was one group that was different from other familial groups. And in screening and in education, we should always work as a team because this is a high risk group. And so it's better to not feel alone when working with a kid like this, creating safety plans where you're just helping the kid discern appropriate warning signs, coping strategies, names of people they would call, hotline, and documenting. Again, to get to the litigation thing, not because that's what I want to focus on, but it's if you do create a safety plan with someone you think has some risk, putting that in the chart that you did that is certainly a helpful thing. Eliminating threats. So, if the kid's thinking about suicide, having the frank conversation with family. We already talked about guns, but also, removing pills that could be toxic and overdose. And then keeping in mind, most of the time, suicidal thoughts are transient. So if you can just sort of keep a kid safe for a few days, that's probably the most helpful thing. So, but the hard thing though is helping parents know when to back off. Okay, so if a home goes into crisis mode where they're kind of watching a kid round the clock for a weekend, they don't know when to stop doing that. And sometimes as providers, we want to be conservative. So we say, well, keep on watching them. But that's also the wrong thing to do too. It sets the wrong tone in the home. It'll make it less likely for the kids to present to their parents that there's problems. So you want to do 48, 72 hours of heightened observation before kind of trying to have an exit strategy for increasing freedom. And, hospitalizations, I don't know if any of you have ever worked in a hospital, and I don't mean this in any disparaging way, but hospitals for kids aren't usually that therapeutic, but they're very good at keeping kids alive. And sometimes just keeping a kid alive for a couple days while they calm down after a breakup can be really useful. I'm not saying that's the cure for every kid, but it is. Paying attention to the transient nature of suicide is very important. And then in terms of more definitive treatment, though, first you got to focus on safety, ameliorating the risk factors that we talked about today, trying to enhance the protective factors, get them more connected, get them developing their problem-solving skills, more of a sense of hope. And then one of the actual formal interventions that's most proven to address suicidality and non-suicidal self-injury is DBT. And that's been more studied in adults, but there's pretty convincing data in adolescents also, even with just DBT skills groups, teaching them the skills. But other interventions have been shown to be helpful too, such as ACT has had acceptance commitment therapy has also shown some preliminary evidence for reducing the risk of suicide. Transference-based psychotherapy has also in one study, as well as good psychiatric management, GPM. So these are all interventions that can be useful. All right. So how do I stop sharing? So that is what I have for you guys today. I fear that I've presented it in a very quick fashion. I'll say Zoom is my excuse for that, for kind of talking fast and not uh, uh, giving brief moments to ask questions. But we have a lot of time. If you guys have questions or cases you want to discuss.
Curious if you, my name's Amanda. I work in the Manchester office. So majority, all of our patients here in Manchester are adult patients over the age of 18. And I'm curious about kind of if you've had experience or done work with the kind of transition from adolescence to adulthood and how to support emerging adults that are struggling with these issues, right? Because I think when our patients get to us, that they're in a place of not having a ton of supports, maybe not having the appropriate care that they needed when they were adolescents. So I don't know, it's kind of a really general question, but I'm curious, about that transition from adolescence to adulthood, emerging adulthood, what we can do kind of at the adult level to maybe support kind of maybe some past, you know, clients that have had past suicidal ideations or suicide attempts, because that's kind of the meat and potatoes of the work that we do is with the adult population. So yeah, I'm just curious about that.
Oh, yeah, this is a great question. Because this is the population I love the most, is the transitional age. And I feel like right now in this cultural moment, it's sort of a lost group. Because for several reasons. There's a perceived less options and opportunities for kids. There's a little bit more of a social disconnect. They spent their final years of high school maybe being done virtually. Um, and it's also a time of drop in connection. So we talked about how connection's a huge risk, safety factor for suicide. And when you leave high school, and if you're not moving on to a job or to some kind of training or education, you're losing a lot of formal connections. So that makes it a risk in itself. So that tends to be my focus. Now, in terms of formal psychiatric and therapeutic stuff, working on frustration tolerance, working on um, recognizing their emotions, communicating their needs. Those are kind of core sort of DBT things. But I think just in terms of kind of problem solving therapy, really putting efforts into building up their connections. So, who are those people you used to hang out with, or those people that you're playing with video games with online? Can you meet up in some way with them? Or can you sort of take those relationships one step further and talk about something other than video games, and trying to build more predictability to their schedule. So a lot of times, kids who aren't launching, in their transitional age, they become hopeless quick, right? Because they're in their I'm just gonna be, I'm thinking of a guy I saw last night. He's in his dad's basement, smoking pot and playing Gears of War all day. And hope is diminishing quickly. So I'm just kind of riffing off of the session we had, but it's sort of how do we build some predictability and regularity to your schedule so you can start structuring a life that you can feel like, okay, well, I've got this landscaping job now. It's not what I dreamt about, but now I have some hope that at least like things can kind of go my way. I can have some money coming in. I've got some ability to do something. So building connection, building hope, recognizing emotions, developing distress tolerance. Those are the biggest things, but I also think it's also an age where substance use is a huge thing, and it becomes a very big comfort, a way to fill up time, and that increases the suicide risk too. And so finding, ways to engage them in motivational enhancement therapy around that. And it's interesting how often people in this age, and I'm even thinking about that guy last night, they understand the risks that, you know, smoking pot all day is doing to them, or they're drinking. And but they don't really know the next steps of what to do. So recognizing if there is some motivation to change, being a now, this is something I think you guys probably know more than me, so I don't want to say too much about this because substance use isn't my specialty, but that's another thing. So finding hope, connection, improving distress tolerance, and addressing the substance use. I think those are the biggest things because it is such a disenfranchised group.
Thank you for your answer. I think that's it's good to think about. I do private practice on the side as well, and I would say the majority of my patients are emerging adults. And what's so interesting about, I think, this kind of generation emerging adults is there's so much insightfulness, right? I think you're exactly right that the struggle tends to be at the place of, I kind of know that this is a problem, I have insight to it, but how do I change it and how do I move forward from it? And especially here with our, you know, population that we work with here in the substance use, is such a huge risk factor. And so we're, you know, managing so many different things, including, you know, the risk factor of active substance use. And so it's helpful to have those ideas about maybe how to approach differently and encourage and increase hope for our patients. So thank you.
Yeah, and the way in which they're using substances can sort of predict risk too. I mean, if they're using when they are the most distressed, the most angry, that's concerning. I mean, all substance use is an increased risk for suicide. But if you add in a lot of like high ticket emotions, like I broke up, I'm angry, I'm gonna go drink a whole lot and get in the car, that's concerning. So maybe okay, you're not planning on stopping your substance that you use, but maybe we can talk about altering when and how you use it. Like, you know, that may be sort of in terms of like risk mitigation, that might be an important conversation. But you know what I like about working with that population is I feel like I learn a lot about myself too, because the gains that could be made could be so slow, you know, and or they could just surprise you with like, oh, you know what I was thinking? I think I do want to get a job and stop doing drugs, and I got the job, and you know, so it's like you're like, wow, where did all that come from? But sometimes learning to moderate my own expectations and goals, because I think, you know, the kids at that age are, they've got all sorts of adults around them that have all sorts of expectations and demands on them, and to care about them but also not to fall into just being another one of those adults is a hard balance. And anyways. All right. Well, I really enjoyed talking with you guys. Just a quick plug. We're looking for someone to kind of do a couple lectures for us on adolescent substance use. So if anybody's interested in providing a like short lecture series, just a couple lectures on substance use to our child psychiatry fellows, I would very much appreciate it. I'll put my email in here. You can write to me if that's something you'd be interested in. Otherwise, I hope you guys have a great Christmas.
Thank you so much.
Have a great day.